So my name is Miranda Lewis. I'm an emergency physician and assistant medical director for Central California EMS Agency. The purpose of this brief talk is to provide some background information on high-performance CPR and talk about why it matters. So what is high-performance CPR? It's expertly performed resuscitation with a focus on minimizing interruptions, providing continuous compressions, delivering compressions at an appropriate rate and depth with minimal interruptions and good recoil, and seamlessly integrating with ALS interventions in a way that prioritizes continuous compressions. So it's all about BLS CPR. Before we get started, I want to acknowledge that much of the content that I'm going to talk about today comes from the Resuscitation Academy. This is an incredible organization that's working to help communities improve survival from cardiac arrest. I encourage you all to check out the Resuscitation Academy website. And the links here are for some of their ebooks created by the folks at Resuscitation Academy, and they're more in-depth than what I'm going to talk about today, but I'd like to introduce some of these important concepts and encourage everybody to check out Resuscitation Academy. It's a wonderful organization. So we're just beginning the process of improving survival from cardiac arrest in our community, and you are part of what we hope will be a change in the way we approach cardiac arrest. And the first thing that we're asking you to change is your mindset. So we're asking you to go into every resuscitation with the expectation that no one in ventricular fibrillation will die. Everyone in VF survives. Expectations influence your performance, and thus expectations become reality. There's a huge amount of variability among communities in survival from out-of-hospital cardiac arrest. When you look at all arrest rhythms, shockable and non-shockable, survival ranges from about 3 to 30%. So there's a 10-fold difference in survival. And that difference is even more pronounced when you look at ventricular fibrillation witnessed arrests. These are the patients that should be the most likely to survive. But the variability is from 4 to 62%, so 15-fold difference in survival among communities. So this begs the question about which factors determine survival from cardiac arrest. You can divide those factors into several categories. There are patient factors. This is things like patient comorbidities, patient age. This is not really something that we can do very much about. Then you can look at event characteristics. And so was the event witnessed? Were there bystanders present who could perform compressions? And finally, there are system factors. And this is where we really have the ability to make an impact. So this includes things like community CPR, telecommunicator CPR, where dispatchers provide instructions on how to perform CPR over the telephone, and bystander CPR. And then, of course, high-performance CPR, which is why you're here today. We can't really impact the patient and event factors, but we certainly have the ability to impact system factors. So next, I want to introduce the concept of the slope of death. At time 0, a cardiac arrest occurs. And every minute that follows, survival decreases by about 10% without any intervention. So by 10 minutes, survival is virtually 0. However, we have the ability to change that slope of death and improve chances of survival by performing high-performance CPR. It takes a system to change the slope of death. It takes dispatch, bystanders, first responders, ALS, medical directors, and hospital personnel. We're all part of the team that it takes to save a victim from cardiac arrest. And I would argue that the most important determinants of survival are dispatch and first on-scene responders, because they are the ones that have the greatest power to change the slope of death. Nothing we do in the hospital makes a single bit of difference if the patient is already at the end of that slope. So this demonstrates how we can influence the slope of death. Bystander CPR slows the dying process. This includes telecommunicator CPR. And high-performance CPR virtually stops the dying process and allows defibrillation, which essentially reverses death. Frequent practice and performance of high-performance CPR and interagency training are critical for improving survival. We want to perform the best high-performance CPR possible so that we can stop the dying process until defibrillation is possible. Let's circle back again to what high-performance CPR is. It's a choreographed and expertly performed resuscitation that is built around quality CPR, including good recoil, appropriate rate, appropriate depth, and very importantly, a high CPR fraction time. CPR fraction time is the proportion of time during a resuscitation that is spent performing compressions. And just to give you a sense of what a high CPR fraction time means, if you're looking at 120 seconds of resuscitation or 2 minutes, if you want a 90% compression fraction, you only have room for 12 seconds of interruptions. So you can see how every single second counts. So when all components of high-performance CPR have been met, a 1% increase in compression fraction equals a 1% increase in survival. And so compression fraction really matters. So this means we need to eliminate every unnecessary interruption down to the millisecond. And finally, I just want to share some numbers with you from Seattle and King County, Washington. So they saw dramatic improvements in their survival with institution of a high-performance CPR protocol. Change is possible and survival is possible. So I think we all strive for a culture of excellence, but we're really asking you to go beyond that and strive for perfection. We are asking you to aim for every single patient to survive their out-of-hospital cardiac arrest and do your best to perform the most excellent CPR that you can.
Welcome to this short PICC Crew CPR review. The next video will show what teamwork can accomplish. Nearly 1,000 persons suffer from out-of-hospital cardiac arrest every day in the U.S. In 2022, we responded to 1,841 medical cardiac arrests. The overall survival to discharge was 10%. This is in line with national statistics. That 10% survival rate is the place in which training and innovation can make improvements. The number one factor consistently reported in study after study to improve outcome is high-quality CPR. HA guidelines for CPR include a rate of compression 100 to 120 per minute, a depth of at least 2 inches on adult patients, complete recoil on every compression, avoid excessive ventilations, and switch compressors every 2 minutes. Additional guidelines for professional rescuers include minimizing interruptions and compressions, the use of feedback devices to monitor CPR quality, and a chest compression fraction of at least 80%, ideally even greater. In addition, we must provide supplemental oxygen during the cardiac arrest. This graphic shows that every compression increases the patient's blood pressure. When we pause to give breaths, that blood pressure falls off dramatically and must be built up again. The longer we can keep compressions going without pauses, the greater and more consistent blood pressure the patient will have. Here are a few examples of PICC Crew CPR in action in various scenarios. My name is Kurt Kindig, and I'm one of the paramedic supervisors at American Ambulance. Today we're going to be talking about PICC Crew CPR. This is a model for providing good, basic CPR and care for the cardiac arrest patient. Our first example is going to be what to do when 2 persons or crew members arrive on scene first. A 2-person crew arrives on scene.
How are you doing, sir?
Sir?
They make immediate patient contact and begin a rapid assessment.
My name is Lexi, this is Jacob. Sir? Sir? I'm checking for a pulse. I don't have one. Jacob, let's go ahead and move this furniture, okay?
Recognizing the patient is in cardiac arrest, they call the code. Together they create a workspace and move the patient to that workspace.
Go ahead and start CPR.
The secondary provider starts compressions-only CPR immediately.
Fresno Medic 129. Can I have a second unit, please? We have a working cardiac arrest.
The primary provider requests backup via radio and begins to place the AED and monitor on the patient. If needed, a shock is provided in a safe manner, and CPR is resumed immediately, switching compressors.
All right, we're fully charged. Everybody stand clear. Clear. Shock delivered. I'm going to take over compressions. Go ahead and get a BVM.
Once the rhythm has been established, airway maneuvers and ventilations can begin.
20, 25, 26, 27, 28, 29, 30.
2 breaths.
The crew arrives on scene and makes immediate patient contact. After a rapid assessment, the code is called. They create a workspace and move the patient. They start compressions-only CPR while requesting backup. The AED is placed on the patient and a shock is delivered if needed. CPR is immediately resumed, switching compressors, and we begin addressing the airway once the rhythm of the code has been established. In this video, we're going to show the differences of what to do when 3 crew members or persons arrive first at a cardiac arrest. The crew arrives on scene and makes immediate patient contact.
Sir, are you alright? Checking for a pulse. There's no pulse, he's not breathing. Move that furniture and let's get him on the ground and let's start CPR.
I got shoulders.
After a rapid assessment, they call the code. Together they create a workspace and move the patient, calling for backup on the radio.
B9139, we have a cardiac arrest in progress. Send it to the units.
With 3 people, we start CPR with ventilations immediately.
10, 20, 25, 26, 27, 28, 29, 30.
Shock the patient if needed in a safe manner,
Analyzing.
and resume CPR switching compressors every 2 minutes.
Don't touch patient. Analyzing. Don't touch patient. Analyzing. Shock advised.
Clear patient.
Don't touch patient. Press flashing shock button.
Shot.
Shock delivered.
Continuing compressions.
With a 3-person crew, the ventilator can use 2 hands on the mask to provide a better seal.
20,
Have a double hand lock.
25, 26, 27, 28, 29, 30.
The crew arrives on scene and makes immediate patient contact. After a rapid assessment, the code is called. Together they create a workspace and move the patient, calling on the radio for backup. CPR is started with ventilations. Patient is placed on the AED and a shock is provided if needed in a safe manner. Resume CPR after each defibrillation, switching compressors every 2 minutes. This video will illustrate what should occur when the ALS crew arrives on scene of a cardiac arrest. The ALS crew arrives on scene.
Hey guys, what's going on?
60-year-old male, 5-minute CPR, 2 shocks.
Okay.
The paramedic gets a report from the first responder and opens a quick log on the Simon. They then direct placement of the ALS gear.
Megan, can you do me a favor and switch the pads over to our monitor, please? Copy. All right. When you get a chance, can you also put an entitled CO2 on? Copy. And Jacob, if you can you put a 4 lead on, please?
Absolutely.
If needed, a shock is provided in a safe manner.
All right, when this cycle's done, we're gonna go ahead and analyze a rhythm, okay?
Copy.
All right, analyzing. Okay, still have VFib. I'm gonna go ahead and charge, continue compressions.
The next priority is establishing IV-IO access with their partner's assistance.
All right, everybody stand clear. I'm gonna deliver a shock. Clear.
Clear.
Shock delivered. All right, continue compressions, please. Jacob, I'm gonna go ahead and look for an IO site. Can you please hand me the IO stuff? And after that, can you spike me a bag?
Okay, sounds good. Here's the IO.
Thank you.
Trust okay.
Thank you.
The initial 3-person BLS team continues to own CPR as the ALS crew works around them. Once the IV-IO access is established, start appropriate treatment protocol. The crew arrives on scene and the paramedic gets a report. Open a call on the quick log. Direct placement of the ALS gear on the patient. Perform a rhythm check and shock patient if necessary. Establish IV-IO access and begin using your treatment protocol. Our last video will illustrate what should occur when the paramedic supervisor arrives with the Lucas device. When the field supervisor arrives, they should communicate with the first-in paramedic.
Yes, please.
Make a decision on the need for the Lucas device, then deploy that device using the BLS crew and existing brakes and CPR.
28, 29, 30.
Okay, pull the patient up, please. Okay, back down. And restart compressions. Okay, now go ahead and stop compressions.
When the field supervisor arrives, they will communicate with the first-in paramedic, decide on the need for the Lucas device, and deploy it. We have just seen some examples of PICC Crew's CPR in action. To review, PICC Crew's CPR is a model of cardiac arrest care that follows both American Heart Association guidelines and CCEMSA policies and procedures. It should be considered best clinical practice.